Welcome to the 8-Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content.
Welcome back to the 8-Minute Rule. We have tried to get rid of the fluff here, so we're just trying to hit with some good clinical content here. Drew got Mark with us today, and I think the big thing we want to do is start off with another tricky case. Drew, go ahead and give us some feedback. I finally got the clock here now. We're going to start it up and go.
All right, so I know we've talked about some lateral elbow pain in the past, and this one looked pretty similar to that initially. It was probably about 2 months, I think, that the patient had been having pain, getting more frequent in intensity. It was fairly isolated just to the lateral elbow. So in clinic, during the eval, we cleared out cervical spine as a main pain generator for this patient, ruled out some peripheral nerve issues, radial nerve, so upper limb tension tests were not positive. And it looked just like a typical lateral epicondylgia or tennis elbow. And then as we were trying to progress this patient, start loading it like we normally would, it just didn't respond like your typical one would with some of the pain-free grip strength, doing some mobilization with movements, which generally help pretty quickly to decrease those symptoms.
All right, so I think what we'll do is try and look at just kind of approaches here. So Mark, why don't you give some thoughts? This patient walks in the clinic, you at least have the information you do from Drew here. And what do you want to look at?
I mean, if it's truly not cervical or peripheral nerve, which is fine, then I'm looking at some almost roundabout ways to target it and load it. I may look above the chain a little bit. I may look below the chain a little bit. Even changing, like if you're doing rows or something, it's not a primary lateral elbow movement, but if you just change like the grip, whether that be have a fat grip or maybe you change supination, pronation, some of those modifications can target those muscles in what may be a more tolerable way for the patient, more indirectly, while also working around the problem area. I would definitely look at blood flow restriction training. That's a way that I've found to be able to load somebody with less tensile forces, but still get some of the same bang for your buck. And there's actually some newer research coming out about BFR with tendon loading and its efficacy in those patient populations. But those would be kind of my go-tos right out of the gate.
Yeah, I think, and obviously, I know Drew mentioned not responding in terms of progressive loading, which can mean a lot of different things, and we're looking at big picture here more than anything else. Yes, I like your thoughts, Mark. I think for me, I know Drew, you mentioned that C-spine was cleared, upper limb tension test being negative. I think maybe my stubbornness I still would want to have some kind of neurodynamics included in here, because I feel like for me, most of these chronic elbow things that are lingering on, that even a little bit, you're going to see some kind of benefit to just getting more blood flow to the nerve. So I would like to include that. Sometimes you can do compression flossing to some degree anywhere along the nerve pathway that you want to. I think here's where some of your instrument-assisted tissue mobility can play in as well. The other thing I like to look at is both sides too. I think sometimes we get super focused on just treating involved side, forgetting, especially from the neurodynamic component, that you're going to have give on either side of the body as well too. So I want to include that. I really like looking at the T-spine and the scapula too. I think anytime that we see something going on at the elbow, there just tends to be something going on there as well too. It's kind of one of those things. Obviously, you're trying all the typical stuff, and I know Drew, you're next to the clinician, and I know you're doing you would have knocked it out of the park if it wasn't, or if it was more of the straightforward. I'd really be hitting on T-spine extension work, scapular mobility work where they need likely upward rotation work, and then trying to load there, and then hopefully you're going to see some things kind of cool down as they go through there. So send it back over to you, Drew. What you got next, or what'd you end up doing after that?
Yeah, so this was a interesting one where I've picked up some techniques from some CHT OTs that I've taught from some weekend intensives, and we're sharing some of our knowledge back and forth because we have a slight different approach than they often do. And one of the things that they had mentioned that tends to often work for them is doing some sort of kind of an axial load through the radius. So if you have them sitting with their arm to the side, and their elbow and their back of their humerus can be up against a wall or a chair, and you actually load that radius, a lot of times you can get a decrease in symptoms. And then if that helps If you do it's almost like a isometric shoulder extension in a supinated position. So if you can see the video, it's like this, where you're pushing backwards into shoulder extension and start doing some loading that way. That can significantly decrease the pain, almost like the mobilization with movement, that lateral glide, that you'll see a significant increase in that pain-free grip strength. It made a pretty significant change doing it with the isometric shoulder extension. And the theory that they have, and this isn't necessarily research based, but it's an N of one for me and N of a lot more for them, where they've seen this being fairly helpful, is the thought that you can have some of that medial elbow instability. Maybe there's some radial head instability that's causing some irritation and pain that's looking just like the tendinopathy. And if you can help stabilize that and start loading it, you can make a lot more quick progress versus like just waiting for it to calm down and progress that way. So fairly quickly, we were able to get to some more loading and gripping, usually starting in that supinated position because that's a lot easier for them, and then moving into a pronated position, and then starting to get some wrist extension and even load all the muscles in that forearm, the wrist extensors, and we were able to progress fairly quickly without it being painful. So that was a nice pickup of a technique, and we've started using it with a second patient that was again struggling just to make progress as I would have expected for your typical lateral epicondylalgia that isn't a like super crazy acute, or someone who's working in a factory where like their job is a major consideration of it. It's just this nagging thing where they can't load it, and early and since it looks like it's going to be another win, so that's two of those like just difficult cases that weren't responding as quickly as I would hope, that have started to make a change by just changing it up and doing that shoulder almost isometric extension and then load from there. And then I'll use this similar progression what I would with like a lateral glide to continue that loading process.
Hey, good stuff. I think all of it pulling back to, can you get the patient in a position where they can tolerate the load? Not to make it sound too simple, but I think the fact of using essentially shoulder extension to be able to allow for that is something I hadn't tried before from the isometric standpoint. I'm excited to give that a shot and see where we get in the futures. All right, that's 8 minutes, guys. Appreciate the quality, and until next time.